Hi everyone, welcome back to the pediatric case discussion series. So the next topic for discussion is going to be nephrotic syndrome. We have divided this session into two parts. Today is the first part where we're going to discuss the basic pathophysiology and the history taking, and the second part we're going to talk about the examination, investigations, treatment, and viva questions, and a lot more theory. Nephrotic syndrome is a broad topic in pediatrics, but it's a very common clinical case scenario. So I'm sure those who've already done their pediatric clinical postings would have seen a nephrotic kid in the ward, or probably those who haven't will definitely see during your pediatric postings. So it's extremely interesting. It's a long topic, and that's the reason why I've divided the topic into like two parts. And today is going to be the first part. So without wasting any further time, let's begin. So the overview of today's discussion, like I said, is going to be the basic pathophysiology, understanding a lot of concepts as to why you have nephrotic syndrome, what exactly happens, why do you have those clinical features, what are the complications, why do you have those complications in nephrotic, etc., etc. And along with that, we're also going to be talking about the history taking part. So let's understand what is the basic of a nephrotic syndrome. So nephrotic syndrome is characterized by increased permeability across the glomerular filtration barrier. Okay. Now the triad of nephrotic syndrome consists of nephrotic range proteinuria, hypoalbuminemia, and edema. Remember this, these are the three main pillars of nephrotic. So you have nephrotic range proteinuria, you have albuminemia, and edema. Now, what do you mean by each of this? What is the definition of nephrotic range proteinuria? What is the meaning of hypoalbuminemia? We'll see this in the next slide. So, nephrotic range proteinuria, why is it called nephrotic range? That's because the amount of proteinuria that you see in nephrotic is massive. There's a lot of protein which is being lost in the urine, and the range is so much high, or so much so that it's called as nephrotic range proteinuria. Okay, so when you have more than 50 milligram per kilogram per day, or more than 40 mg per meter square per hour, both of these values are in a 24-hour urine sample. Okay, so you need to collect the sample over 24-hour period, and then you need to estimate the amount of protein that's present in the urine. So if it's more than 50 mg per kg per day, or more than 40 mg per meter square per hour in a 24-hour urine sample, then you would call it nephrotic range proteinuria. Or an easier way of defining this is if you take a spot urine sample. Okay, in that, if you do a urine protein by urine creatinine ratio, if that ratio in a spot urine sample is more than 2, then you would call it nephrotic range proteinuria. The third thing, or the easier way out, is you do a dipstick method. Okay, so I'll tell you what a dipstick method looks like. But on the dipstick, if the reading is more than equal to +3 on an early morning sample, then you would call it nephrotic range proteinuria. So if the definition doesn't fall into this, like say there's minimal amount of proteinuria which is not fitting into this definition, you would not call it nephrotic range proteinuria. Okay, proteinuria can have a different range from minimal to nephrotic range. So if you have less amount of proteinuria, then it doesn't fall into this definition of nephrotic range proteinuria. Okay, so that's the first thing, nephrotic range proteinuria. Second is what is hypoalbuminemia. Okay, so hypoalbuminemia is defined as your serum albumin less than 3 gram per deciliter. Remember that all the definitions, all the concepts, predominantly the definitions, complications, etc., that we're going to be talking about today are according to the ISPM 2021 guidelines. Okay, so a few things might have changed as compared to the previous one. So it's the Indian Society of Pediatric Nephrology. So that's the ISPN 2021 guidelines. So in that, they have defined hypoalbuminemia as albumin less than 3 gram per deciliter. Initially, it was less than 2.5. So just remember that's the change according to the new criteria or the new definition or new guidelines. So you have nephrotic range proteinuria, you have hypoalbuminemia, and the third pillar or the third triad of nephrotic is your presence of edema. Now, this is what a dipstick test looks like. I'm sure pretty many of you would have seen what a dipstick is. So this is the stick which has got different colors, and this is the bottle which has the label on it. Okay, so you need to dip this strip into the urine sample. for the specified amount of time. So if you look here, it mentions 60 seconds. Okay, different bottles by different companies, different pharmaceutical products will have the amount of seconds written as to how long you need to dip the stick in the urine sample. Okay, because if you like dip it for a shorter period of time or probably longer than it's recommended, then you might have erroneous readings. Okay, so here if you talk about this dipstick, you're supposed to dip this strip, which has these different colors, in the urine sample for 60 seconds. And then you look at the change in color and compare it. Okay, so if you look at this, the second bar here is for the protein, and it resembles this green color, which is closest to this sample that's available on the label. Okay, so this is like, I guess, +1. So this is +1 protein in the urine. Okay, so like this is an easy way out of doing a spot urine protein uh, measurement. So if you have more than equal to +3, so if you have either +3 or +4 on the dipstick on a morning sample, then you would call it nephrotic range proteinuria. Now these are the definitions. Now remember, proteinuria is like the crux, or it's the most important pathology that happens in a nephrotic. Now let's look at why do you get proteinuria in nephrotic. Okay, so there's increased filtration of macromolecules like albumin across the glomerular capillary wall. Okay, so albumin is a big molecule. Normally, it should not be filtered across the glomerulus and should not come into the urine, but probably something is not right, something is wrong, as a result of which these big macromolecules are able to make its way out of the glomerular capillary wall and be excreted in the urine. Okay, so normally what happens when you have the filtration of macromolecules across the glomerular wall, it's normally restricted by two mechanisms. There's charge sensitivity and there's size sensitivity. Okay, so what happens is, if you look at this image over here, this this is the endothelium, this is the glomerular basement membrane. These are the food process of the podocytes. Okay, and this is the urinary space, this is the capillary lumen. Okay, so basically, if there is uh, filtration of macromolecules, they will move from the capillary space into the urinary space and be excreted out in the urine. So what happens in the normal scenario is that the endothelial cells and the glomerular basement membrane, they both are negatively charged. Okay, so they're negatively charged because they have certain compounds called heparin sulfate, which is charged, as a result of which it acts as a barrier for the negatively charged albumin. Okay, so the GBM and the endothelium are negatively charged because of these proteoglycans, and they don't allow albumin, which is also negatively charged, to travel across them to be excreted in the urine. But what happens in certain types of nephrotic, let's talk about the minimal change disease, which is the most common type of nephrotic that we see. There is a loss of this anion charge. Okay, so there's loss of this negative charge on the GBM and the endothelium, but there's no accompanying structural change in the GBM. Okay, so there's loss of the charge or loss of anion, but there's no structural change, and that's the reason why you will not see any abnormality on the light microscopy. Okay, in an MCD or a minimal change disease, the light microscopy appearance will be normal. What will be abnormal is your electron microscopy findings, which we'll see in the further slides. But because it's a loss of the charge and structurally normal barrier, you will not have any change visible on the light microscopy in a minimal change disease. Whereas if you look at the other types, like if you have the membrane or proliferative or the mesangial or the secondary types of nephrotic, another thing that is offered by this barrier is that they have pores of a certain size. Okay, so you have GBM capillary walls have pores of radius 40 to 45 amperes. In nephrotic, other than minimal change disease, there is increase in the size of these pores. Okay, so when the size of these pores increase, it easily allows the macromolecules to travel from the capillary lumen into the urinary space and be excreted out in the urine. So these are the two main mechanisms as to how the protein or how albumin is able to exit or able to translate or move across this glomerular capillary wall and be excreted in the urine. Okay, I hope this is clear. Moving ahead, what is the classification of nephrotic syndrome? So you can broadly classify nephrotic into three types. You have primary, secondary, and the third one is either congenital or infantile. So primary, also called as idiopathic, is the most common type. Again, the most common histopathology will be minimal change disease. Secondary cause of nephrotic syndrome are the ones that have a poorer prognosis. They have more significant lesions like focal segmental glomerulosclerosis, membranous or membranoproliferative nephrotic syndrome. Okay. And the third one is congenital or infantile. The definition is only on the basis of the age. So the congenital nephrotic presents less than 3 months of age, and infantile presents less than 12 months of age. Okay, so depending on the age at presentation, you can classify them as congenital or infantile. They have a lot of genetic causes as to why they happen, and we'll see them in the next discussion. So now that you've understood the definition of primary, secondary, and congenital, there are certain causes of secondary nephrotic syndrome. Okay, so this is and again another common question that can be asked in the Viva, that what are the causes of secondary nephrotic? What you need to remember is about 4 or 5 of them. So most common infections, you have HIV, hepatitis B, C, malaria, toxoplasmosis. Second is vasculitis like SLE and Henoch-Colin purpura, HSP. Third one is drugs. You can have drugs like NSAIDs, penicillamine, gold salts. These also can cause secondary nephrotic. And last but not the least, malignancies like Hodgkin's and non-Hodgkin's lymphoma are also secondary causes of nephrotic syndrome. Okay, so when you're asked the classification of nephrotic or types of nephrotic, you have to say primary, secondary, and the third one, which is either congenital or infantile. And you might be asked as to what are the secondary causes of nephrotic. This is also important to understand because when you're suspecting a secondary cause of nephrotic, you need to know the causes because your investigation as to what is the cause of nephrotic will depend on what you think is the etiology. Okay. So this was the classification of nephrotic. Now, having done with the basics, let's present an actual case of nephrotic syndrome. So demographics. So usual common age of presentation of a nephrotic is around 2 to 7 years of age, but it ranges over a span of 1 to 12 years. So usual age of presentation is somewhere around, like I said, 2 to 7 years, and it is more common in males. So let's assume this case is a 4-year-old male child, second by birth order, born of non-consanguineous marriage, resident of Mumbai, informant being the mother who's reliable, who's come with chief complaints of puffiness around the eyes, say since 7 days, swelling of the lower limbs and abdomen since 3 days, and decreased urine output since 1 day. Okay, so the chief complaints, like I said, are puffiness around the eyes for 1 week, swelling of the lower limbs and abdomen since 3 days, and decreased urine output since 1 day. Okay, so basically what I'm talking about is that there is some kind of fluid accumulation, some kind of edema that's going on associated with decreased urine output. This is what I am thinking of when the mother is giving me these chief complaints. Now, how do I elaborate each one of them? So what is the history of presenting illness? So the child was apparently all right till 7 days back when the mother noticed puffiness around the eyes, which was insidious in onset, which has been gradually progressive in nature, which is associated with diurnal variations. This is very important, and this question is not something which the mother will give you an answer for unless and until you ask for it. Okay, so it's very important that when you have edema of any part of the body, you should always ask for diurnal variations. You should always ask for how the edema appears, when is it maximum, what happens that the edema resolves, does it resolve on its own, etc., etc. So when I'm asking about diurnal variation in this case, the mother is telling me that the edema is more in the morning and then reduces as the day progresses. Okay. Having said that, so now I know that there is puffiness around the eyes, which is insidious in onset. So ODP is important. Your onset, duration, progress. Duration we know is present for the past 7 days. Onset has been insidious. Progression, it's been gradually progressing in nature, associated with diurnal variation. Okay, now usually what happens is when there's onset of edema, particularly when we're talking about nephrotic, there is usually a triggering factor or an inciting factor which precipitates the onset of edema. And in most cases, it is almost always an infection. Now, infection can be a URI or a UTI. So you need to ask for symptoms of infection, probably that preceded the onset of edema. Okay, so how will you ask for questions related to UTI? So there's burning micturition, increased frequency, urgency, crying while micturition, depending on the age of the child. For URI, you can ask for fever, cough, cold, runny nose, etc. So you should always ask for if there is any history of infection preceding the onset of this puffiness around the eyes. Now, the next complaint that the mother gave was swelling of the lower limbs and abdomen. Okay, that was again insidious in onset, progressively increasing. So it started with the ankle and now has gradually progressed up to the knees, gradually. Again, associated with diurnal variation. So it's more in the morning and reduces as the day progresses. The third complaint is decreased urine output. Now, how will the mother quantify or how will the mother feel that the child is passing less amount of urine as compared to normal? So you need to ask this as to how many times did the child pass urine, when the child was doing okay, like apparently all right, probably 1 week back, 10 days back. So initially the child say passed urine about 6 to 7 times per day, but now the frequency has reduced to once or twice per day. Okay, so that is why the mother now feels that there is decreased urine output because my child is not going to pee as much as he used to do otherwise. Along with that, two important questions that you need to ask with respect to decreased urine output is whether there's history of concentrated urine and whether there's associated frothing. Now, when you have less amount of urine being produced, you will always have associated concentrated urine. So urine will be small quantity and dark colored. And another interesting feature of the urine in nephrotic is that there'll be associated frothing. Why do you have frothing? So basically, when there's associated massive proteinuria, you have loss of all your albumin in the urine. It results in frothing. So this is what it looks like. Okay. So look at the amount of frothing that you can see at the top. And this is when the child is just past urine. This is not what a normal urine looks like. So this frothing along with concentrated small quantity dark colored urine with decreased urine output, all of these are suggestive of the fact that urine output is decreased, frothing is suggestive of massive proteinuria, and concentrated urine will be small quantity dark color. So these are the set of questions that you need to ask in detail about your chief complaints to get your history of presenting illness. Okay, so here my complaints were puffiness around the eyes, swelling of the lower limb and abdomen, and decreased urine output. Now we know that we're talking about some kind of edema. Okay, so there's periorbital edema, there's pedal edema, there's probably ascites, and associated with decreased urine output. Now, so we know we're dealing with edema. Now that we know that there is edema of some kind, but we don't know what the cause is. Okay, so the next question that we need to ask is the what are the possible causes of edema? So to be able to take a good history and be able to, be sure that these are the causes that are possible, these are the causes that are probably not related to this case, you should know the causes of edema. And edema is uh, such a concept that each cause of edema will have a particular way that the edema appears and disappears, whether there's associated diurnal variation or not, whether there are associated other clinical conditions or not. So what are the four main causes of edema? So first is renal. Now what is so peculiar about renal edema? So renal edema, basically edema due to a renal cause, starts with periorbital edema first in the morning. Why does that happen? Because there's a lot of loose connective tissue around the eye, and when the child has been supine, that is one of the dependent areas of the body. It's periorbital edema that starts in the morning and it's maximum in the morning, and then it is followed by the legs and abdomen as the day progresses because the edema becomes dependent edema, and as the day progresses, when the child is upright, standing, it's the legs and abdomen that become the dependent portions of the body. Okay, so typically, if you have edema of renal origin, it'll start with periorbital puffiness maximum in the morning. As the day progresses, the periorbital puffiness reduces, and you will have more edema in the dependent portions of the body, which is the leg and abdomen. Second cause of edema could be cardiac. Now, in a cardiac cause, you will have edema in the lower limbs first. Why do you have edema in cardiac cause like in CCF? So basically, the heart is weak, it cannot pump blood to the body. So blood starts accumulating in the veins, and the blood begins to pool first in the feet and the legs. And that's the reason why in a cardiac cause, you will have edema first in the lower limbs. And obviously, associated with that, you will have cardiac symptoms as well. Third is hepatic cause. So hepatic cause, when you have your liver involvement, it's going to be ascites first, followed by pedal edema. Now, why do you have ascites? Because you have portal venous congestion. You have low albumin production because the liver is cirrhosed, liver is not functional, and albumin is produced in the liver. So you have increased capillary hydrostatic pressure, increased capillary permeability, decreased oncotic pressure because you have decreased albumin, as a result of which you have exudation of fluid in the abdomen and you have ascites. So in hepatic cause, you will have ascites first, followed by pedal edema. Lastly, the fourth common cause of edema can be nutritional, like in kwashiorkor. Now, in nutritional cause of edema, again, the edema predominantly starts in the lower limbs first and also can involve the abdomen. But along with just edema, you will have skin changes, mental changes, and other symptoms associated with nutritional deficiencies. So that this is the reason why you need to ask your questions in detail about the onset and progress of the edema in a nephrotic or in any case, because it will give you an idea as to how the edema starts. Is there any diurnal variation? What part of the body is affected the most? And whether or not the edema resolves as the day progresses, worsens, are there any other symptoms associated or not? Okay, so now that we know that these are the possible causes of edema that we need to rule out from our history, what negative history will you ask for? So the first thing, so if I'm wanting to rule out a cardiac cause of edema, so whether there's history of breathlessness on exertion, chest pain, dyspnea, or orthopnea. For hepatic failure or hepatic cause of edema, I'll ask for yellowish discoloration of skin, blood and vomitus, or blood and stools. For kwashiorkor, I'll ask for history of appetite change, skin changes, or irritability. So my point number 1, 2, and 3 are related to what are the differential diagnoses or possible causes of edema. So I don't have any of this in my case. So most likely my cause of edema is a renal origin. Now, like I said, you need to ask about precipitating causes of edema. So for UTI and URI, you'll ask for fever, crying while micturition, burning micturition, increased urgency, frequency, or history of fever with hurried breathing, cough, cold, runny nose for a URI or a LRTI. Now, the third thing or the third set of questions in your negative history or your history of etiology are going to be related to what is the cause of the renal origin of edema. So, like I said, if you're talking about nephrotic range or if you're talking about nephrotic syndrome, you can have primary, secondary, and congenital or infantile, depending on the age. So, in secondary causes, we saw it could be either infection, vasculitis, malignancy, drugs, etc. So, how do you rule out on the basis of history that whether this is like a primary cause of nephrotic or whether this could be a secondary cause? So you'll ask for history of rash, bone pain, joint pain to rule out any connective tissue disorder, vasculitis, or malignancy, which could lead to a secondary cause of nephrotic. History of drug intake. So what drug history will you want to ask? Either NSAIDs, captopril, penicillamine, gold salts. All of these again can lead to secondary nephrotic. The third one, very important, is nephritic syndrome. Okay, so there is a certain amount of overlap between nephrotic and nephritic. There are certain features which are similar, there are certain features which are very distinct between the two. So it is very important that any child who's presenting with any kind of pathology which you think is of renal origin, you should always ask for symptoms of cola colored urine or dark colored urine or red colored urine associated with headache and blurring of vision. Why am I asking these questions? Is to rule out or to ask about the possibility of nephritic syndrome. Now, having said that, what is the difference between a nephrotic and nephritic? I'm sorry, there's a typo. It should be nephrotic versus nephritic syndrome. So remember, nephrotic syndrome will have massive proteinuria or will have nephrotic range proteinuria, whereas nephritic syndrome is predominantly characterized by hematuria. So they'll have more cola colored urine, dark colored urine. They do have some amount of proteinuria as well, but it is not as massive as a nephrotic range proteinuria. Second is hypoalbuminemia and gross edema. So the triad of nephrotic, which is nephrotic range proteinuria, hypoalbuminemia, and edema, are a part of nephrotic. So you will have hypoalbuminemia and gross edema, whereas in nephritic, edema will be minimal. You will have more hypertension in a nephritic, and that's the reason why when we ask for a set of questions of headache and blurring of vision, That is because you want to ask about symptoms of hypertension or hypertensive encephalopathy. Okay, so nephritic syndrome is commonly associated with hypertension, whereas nephrotics have more of generalized edema. You also have hyperlipidemia in nephrotic. Nephritic will have more of oliguria, but will not have hyperlipidemia. And most importantly, the age of presentation is different. So nephrotics usually present between 2 to 7 years of age, predominantly on an average, whereas nephritic kids are slightly older, like about 5 to 15 years of age. So this is the difference between nephrotic and nephritic. Again, a very favorite question in Vivas, that how will you differentiate nephrotic versus nephritic? So this has massive proteinuria and a lot of edema associated with hyperlipidemia and age of presentation, whereas nephritics will have more hematuria, hypertension, minimal edema, some amount of oliguria, and they are usually seen in older kids. So this is the difference that you need to know between a nephrotic and nephritic syndrome. So the previous set of questions that we asked in the negative history or the history of etiology was to rule out the causes of edema, whether or not this is a secondary cause of nephrotic syndrome, and what was the precipitating cause of this edema in this child. I hope this is clear. Moving ahead, now we have spoken a lot about there's edema, there is nephrotic range proteinuria, massive edema. Now, why, to understand the basics of why is edema so prominent in nephrotic? You might have seen kids in the ward come with periorbital puffiness, pedal edema, they're bloated. Now, why do you have edema in nephrotic syndrome? So there are two basic hypotheses which go behind why you see edema in nephrotic. The first one is very simple to understand. So you have proteinuria, okay? So you have loss of albumin or loss of protein in the urine, as a result of which your serum albumin decreases. So you have hypoalbuminemia. Now we all know that it's albumin which is a major protein in the vascular space. When you have loss of that albumin, your oncotic pressure in the plasma decreases. Okay, so because albumin is the predominant factor which regulates the plasma oncotic pressure. So when you have loss of albumin, you have hypoalbuminemia, you would have decreased plasma oncotic pressure, as a result of which you have increased capillary hydrostatic pressure. So usually you have a balance between the oncotic and the hydrostatic pressure, but when you have hypoalbuminemia and decreased oncotic pressure, your capillary hydrostatic pressure increases, as a result of which what happens is that there is transcapillary filtration of fluid into the interstitial space. So all the fluid volume that was supposed to remain in the vascular space now starts moving or starts filtrating into the surrounding interstitial space. Okay, so your intravascular volume per se reduces because fluid is going into the interstitium and causing edema. Now, what happens because you have decreased fluid in the vascular space? You have reduced intravascular fluid volume. Now, it's the intravascular fluid volume that basically causes perfusion of all your vital organs. Okay, so when you have decreased intravascular fluid volume, there's reduced perfusion of the kidneys, okay, because the kidneys are not getting as much blood volume as it normally should. As a result of which your GFR decreases, okay, your glomerular filtration rate decreases. This activates your RAS, your renin-angiotensin system gets activated because of decreased perfusion of kidneys, decreased GFR. Now, what is the function of renin-angiotensin? It increases sodium and water retention. Because it senses that, oh, the intravascular volume is reduced, probably the patient is hypovolemic, okay, and we need to retain more sodium and more water. So what happens is once your RAS gets activated, it will cause more sodium and water retention, and that will result in more and more edema. So it's like a vicious cycle wherein it starts with hypoalbuminemia, proteinuria, decreased oncotic pressure, increased transuration or your trans capillary filtration into the interstitium, decreased intravascular volume, activation of RAS, more sodium and water reabsorption, and more edema. I hope this is easy to understand. So this is what is called as the underfill hypothesis. Now there is an other hypothesis which is also thought that probably this could be the cause of edema in a nephrotic. So there are certain intrinsic defects in the renal tubules, okay, especially in your distal collecting and the connecting duct. So what happens is because of the intrinsic, or you can say probably genetic intrinsic defect in the renal tubules, you have reduced sodium excretion. So when you have sodium being retained, along with that water gets retained. So you have increased sodium and water retention, and which again in turn leads to more edema. Okay, so overfill hypothesis was kind of believed because not all cases or not all patients with nephrotic have hypovolemia or have reduced intravascular fluid volume, but they still develop edema. Then what is the reason for that? So that is why you have these two hypothesis, the underfill and the overfill hypothesis, which are probably the causes of edema in a nephrotic. Now remember, edema starts becoming visible when it exceeds about 3 to 5% of body weight. Okay, so it's only when there's like significant amount of edema will you start seeing that the child looks puffed or the child looks edematous. So this is the mechanism of edema in nephrotic. What is the mechanism of oliguria? If you've understood edema, this becomes very, very easy to understand. So the same thing, you have proteinuria, reduced oncotic pressure, there's more fluid in the interstitium, reduced intravascular fluid volume, which reduces the kidney perfusion, reduces GFR, your renin-angiotensin gets activated. So again, you have more reabsorption of sodium and water, and because more of it gets reabsorbed, there's reduced production of urine and reduced urine output. So that is the reason why these kids who have proteinuria, have hypoalbuminemia, eventually have oliguria. So I hope this triad and this concept of nephrotic is clear. Now, moving ahead, what are the complications? So the next set of questions that you need to ask in history after history of etiology or negative history is history of complications in nephrotic. So if you have to broadly classify complications, they can be either acute or chronic. So let's concentrate on the acute complications first. So you can have either infection, thrombosis, or AKI or acute kidney injury. Now, why is it that these kids with nephrotic are having an increased risk of infection? So what happens is when you have proteinuria, along with loss of albumin, there's also loss of other renal proteins. I mean, renal loss of other proteins like immunoglobulins and your alternate pathway factors like factor B and D. Along with that, they also have impaired ability to make specific antibodies. And these patients with nephrotic are on long-term immunosuppressive therapy. They might be steroids, they might be steroid-sparing agents, they might be agents like cyclophosphamide, cyclosporin, tacrolimus, rituximab, etc. So we'll see these drugs in the next discussion when we talk about treatment of nephrotic. But they have immunosuppressive therapy, which is going on for a longer duration of time. And this is the reason why they are at more risk of infection than a normal child. So they have loss of all the immunoglobulins in the urine, decreased ability to produce certain antibodies, and chronic immunosuppressive therapy. So most commonly, they are prone to bacterial infections with encapsulated organisms like Streptococcus, Pneumococcus, and Haemophilus influenza. Why so? Because they have loss of immunoglobulin G and other factors that are required for opsonization of these encapsulated bacterial products. Okay, that's the reason why it's important to vaccinate these nephrotics with these special vaccines, specifically targeting the encapsulated organisms. The next common set of infections that you can have is viral infections, again, the most common being varicella. Now, most common infections that you would see in a nephrotic are peritonitis, pneumonia, and empyema. Okay, so I hope this is clear as to why are these kids more prone to infection than a normal child. The next thing, what are the mechanisms of thromboembolism? So I said that they are at a risk of thrombosis. Now, why is it so? Now, usually there's a balance in the body in a normal scenario between the production of procoagulant and anticoagulant factors. But what happens here is that that balance is lost. So there's increased production of procoagulant factors like antithrombin 3 and protein CS. And at the same time, there's urinary loss of anticoagulant proteins like factor 5, 8, and fibrinogen. So as a result of this, there is increase in the concentration of the procoagulants in the body. That's one reason. Along with that, they have hemoconcentration, like I said, because of the reduced intravascular fluid volume or hypovolemia. So they have hemoconcentration. Along with that, so basically when you have hemoconcentration, it causes like sluggish blood flow and increased risk of, the blood getting more stagnated and the risk of thrombosis. Third one is thrombocytosis or platelet activation, which is also seen in nephrotics. And the last but not the least, in those patients who have anasarca, who have generalized edema, massive edema that they're not able to move around. So immobility is another cause that predisposes them to thrombosis. Now, what are the common site of thrombosis in a nephrotic? You can have cortical vein thrombosis, so in the brain, you can have renal vein, pulmonary artery causing pulmonary embolisms, and other veins like you can have deep leg veins, IVC, hepatic vein, even femoral artery. All these are common sites of the formation of thrombus or thrombosis in a nephrotic. So remember the causes are increased production of procoagulants, loss of anticoagulants, hemoconcentration, platelet activation, immobility, and thrombocytosis. These are the common reasons as to why these kids are at a higher risk of thrombosis as compared to normal kids. And you should know at least a few common sites of thrombosis that these kids can develop. Okay. So the third one, like I said, acute complications was AKI. So again, acute kidney injury because you have reduced intravascular fluid volume, causing hypovolemia, hypotension, reduced perfusion of the kidneys, which can predispose to acute kidney injury because basically your renal perfusion is getting impaired. So these are the three common complications of or common acute complications of nephrotic. Let's talk about chronic complications. So common chronic complications could be first is growth retardation because it's a chronic disease and there's long-term use of steroids. Other common complications could be anemia. So why are these kids again more at risk of anemia? Because they have urinary loss of iron, transferrin, erythropoietin, and other metals like copper. And the third thing is they have persistent hyperlipidemia, hypercholesterolemia, hypertriglyceridemia, which increases their risk of early atherosclerosis. Now, why is it that they have an increased risk of hyperlipidemia? Is because of increased synthesis and impaired catabolism of lipoproteins, which contain cholesterol and apolipoprotein B. So basically, again, there's an imbalance in the production and the metabolism of your cholesterol, as a result of which they can have hyperlipidemia, which again increases their risk of premature atherosclerosis. So we know what the complications of nephrotic are in acute and chronic. Now, how will you ask for questions to rule out those complications? The first one is headache, history of headache, blurring of vision, altered sensorium, and convulsions. All of this could be either to rule out a thrombosis of the cortical vein or cerebral vein, or it could be to rule out hypertensive encephalopathy. So the symptoms will be pretty much the same in both. They will both come with these CNS complaints of headache, blurring of vision, convulsions, etc. So when you ask for these set of symptoms, it could either be to rule out hypertensive encephalopathy, which would be more common in a nephritic syndrome, or also to rule out the complication of nephrotic, which is thrombosis of the cortical vein. Next is SBP. What is SBP? It is subacute bacterial peritonitis. So we just saw why infection is more common in these kids. So SBP presents with abdominal pain, vomiting, reduced appetite, loose stools, etc. Renal vein thrombosis will present with massive flank pain and massive hematuria. Okay, so this is another complication that you might ask for because again these kids are more at risk of thrombosis, and especially if the patient is say a known case of nephrotic, has had multiple relapses in the past, has been on chronic steroid or chronic immunosuppressive therapy, you should ask for history of complications of steroid toxicity or long-term steroid use, which is stunting or growth failure. Now, what are the other complications of nephrotic? You have difficulty in getting up from squatting position. So basically, it's proximal myopathy. Common complications of prolonged or long-term steroid use. You have short stature or growth failure. You will have difficulty in getting up from the squatting position or proximal myopathy, both in the upper and the lower limbs. You can have cataract. You can have loss of mineral bone density or increased risk of fracture. So these questions need to be asked specifically in those kids who have had nephrotic syndrome as a chronic disease and have received immunosuppression for a longer duration of time. So these are the common complications of nephrotic. We saw why they develop these complications, what are the symptoms, and how do you ask for history of complications in your history taking. Or just interesting things as to what are the causes of dyspnea in a nephrotic. So when a nephrotic hit is coming with, say, increased work of breathing or rapid respiration, remember it could be either because of massive ascites, which is either pushing up the diaphragm. It could be associated with because of fluid diffusion. They might have a pneumonia, which has probably precipitated this episode of nephrotic. Or remember, very common but important and something that you should not miss out on is the possibility of pulmonary embolism. We just saw why they're at a risk of increased thrombosis, and that thrombus can travel and occlude the pulmonary artery, resulting in pulmonary embolism. So these are the common causes of nephrotic dyspnea in a nephrotic. What are the causes of pain abdomen? So when a kid with nephrotic is complaining of pain abdomen, we just saw it could be bacterial peritonitis. It could either be gut ischemia. Okay, so when you have hypovolemia, just like your renal perfusion is getting impaired, you could also have impaired gut perfusion. So it can lead to gut ischemia. Prolonged steroid use can cause gastritis, which can again cause pain abdomen. And lastly, a long-term steroid complication could be pancreatitis. So when you have, why am I pointing out these things? Is these things are more important from a clinical perspective. So when a kid of nephrotic is coming with dyspnea or say is coming with pain abdomen, you need to have these differentials in mind and then do your history taking and examination in detail so that you will be able to, more confidently say that probably this is, I think, the cause of the dyspnea or this is the cause of pain abdomen in your patient. Okay. So these are commonly encountered symptoms in a nephrotic, and that's the reason why you should know the causes for both of them. Now, next is treatment history. So remember, treatment history, I would like to ask with respect to this particular episode. So say if you're taking the history on day 4 of admission, okay? So you need to know what has happened from the time of admission in those previous 4 days. So whether the child was started on any IV medications, so the mother will know that, whether antibiotics, diuretics. Again, a lot of parents do know, and we often tell them when we start them that we're giving this to probably try and increase the urine output so that the edema starts resolving. Or sometimes IV albumin may also be given as an IV medication. We'll see later as to why and when is albumin given. But these are the common IV medications that we might start in a nephrotic who's presenting with edema. Now, in the those days that the child has been admitted in the hospital, has there been any relief of symptoms after starting treatment? So probably when you ask for this, whether there has been any relief or it's been the same or has gotten worse, the informant might tell you, yeah, that the edema has started resolving, the urine output has increased, depending on what the history is. So whether or not there has been any relief since starting treatment or since admission, and the third very important thing is whether or not the child has been started on steroids. So can anybody tell me how will you ask the informant whether or not steroids have been started for that patient? What I'm asking is how will you ask for history of steroid for treatment in this episode to the mother on history taking? So basically to make it simpler, how are steroids usually given or how are they prescribed when we started for nephrotic syndrome? Does anybody have any idea? You can try answering. Okay, someone is saying it's given with milk. Okay. Anything else? Is it given once a day? Is it given twice a day? Okay, so we'll come to this at the end of the class. I am giving you guys time to think about this question as to how will you ask for the history of steroids to the informant, whether the child has been started on it or not. Twice, someone saying twice a day. Okay, that's also right. Okay, so I'll give you the answer at the end of the class. Next thing is past history. Now, past history becomes extremely important in a child with nephrotic. Why so? Because you want to know whether this is the first time that the child is presenting with these complaints, or is it like a relapse? But the child has already been diagnosed with nephrotic and has had multiple relapses in the past. How often has the child relapsed? What treatment is the child taking? Whether or not the child is responding to the treatment that has been prescribed, what is the compliance of therapy that has been prescribed. It happens many a times that you've started steroids and you told the parents to continue it for like 6 weeks and then come and show you back so that you can taper the dose, but sometimes they are just lost to follow up. So probably the child responded to steroids, but because he has not received complete treatment, he has come with a relapse. So a lot of things go into your history about past treatment. So, what is the history of similar episodes in the past? Now, age of onset, like I said, usually it presents between 2 to 7 years, but you can consider 1 to 12 years. If it falls beyond this range, like if it falls less than one, like if the onset was say less than 12 months of age, I'll call it infantile nephrotic syndrome, right? If it's more than 12, then again it starts having features of atypical nephrotic. So my line of investigation, my treatment will slightly vary as compared to a minimal change disease as a classic nephrotic syndrome. So what is the age of presentation? How many episodes or how many relapses have occurred in the past? What was the treatment received in each episode? Okay, so was it that the child required admission? Was it that he had massive edema, massive proteinuria, and he had dyspnea and other complications, he had to be admitted? Or was it just OPD basis treatment? Whether the child has been started on steroids and whether he relapsed on steroids. So why are these questions again more important? Because I'm trying to classify the patient as either steroid sensitive, whether he's steroid dependent, whether he's steroid resistant, or whether he's a frequently relapsing nephrotic syndrome. Okay, these definitions or these terms might sound confusing, but it's very important to understand why, because the treatment options for each one are very different. So you will treat a non-frequently relapsing nephrotic different from a steroid resistant or a frequently relapsing steroid sensitive nephrotic syndrome. So we'll see what these definitions are, but the reason why you need to ask for questions about the past treatment is to classify this patient as whether he is responding to steroids, whether he's steroid resistant, whether he's frequently relapsing, etc. So you'll ask for number of relapses in a year, whether he's relapsed on steroid, that's a steroid dependent nephrotic syndrome, what other drug history or what other medications has he received, so whether he's had hypertension, whether he is on antihypertensives, whether he's receiving other steroid sparing agents or other immunosuppressive drugs like cyclophosphamide, cyclosporin, tacrolimus, rituximab, etc. Whether there's history of, like I said, steroid toxicity because of long-term steroid use, so you have delayed growth, obesity, fracture, visual abnormalities. And very important to ask is whether there's history of COX or COX contact. Why is it important? Because the mainstay of treatment in nephrotic is steroids, and it is very important for you to rule out tuberculosis before you start steroids. Because in case if the child is having tuberculosis, latent tuberculosis, has had a history of tuberculosis contact, the disease might flare up when you start steroids. So it's always very important to rule out tuberculosis before you start with steroids in a nephrotic. So these are the set of questions that you will ask in your past history, and these are extremely important because at the end, when you give your final summary at the end of history taking, you'll be able to say whether you feel this is a non-frequently relapsing or this is a steroid resistant, etc., etc. Okay. So next is family history. So you will draw three generation pedigree chart, and you will ask for similar history in other family members. In the antenatal birth and postnatal history, there's nothing which is uh like I would say particular or specifically different to be asked in a case of nephrotic. Your set of questions of your antenatal, first trimester, second trimester, third trimester, birth history, neonatal history are going to be just the same like any other case. And that's the reason why I'm not stressing out on it here, because we've discussed it previously and there's nothing that needs to be emphasized in this case. So that's the reason why I've said uneventful. But for you, when you take a history of nephrotic, these questions, like any other case, have to be asked in detail. Now, diet history, again, you need to ask about protein and calorie intake. And then you calculate expected and observed, and then you calculate the deficit. What is more important from a nephrotic perspective in the dietary history is you need to ask about excess sodium intake. Okay, so we just saw that when you have excess sodium, it causes excess water retention, you'll have more edema. So, what are the sources of excess sodium intake in the food? So, all your fried chips, bread, processed cheese, pickles, junk food, preserved canned food, all of this will have more sodium. So, you don't want these kids to consume more sodium because they'll retain more water and have more edema. So, you will ask specifically for increased sodium intake in your history, and again increased intake of saturated fats. We just saw that they also have a risk of hyperlipidemia, hypercholesterolemia. You don't want them to accumulate more and more fat. So you also will ask for history of whether their diet has more content of saturated fats. So sodium and saturated fats are two important histories that you will ask in diet in a nephrotic case. Immunization, again, as per the national immunization schedule, but along with that, what is important is whether special vaccines have been taken. So we just saw that they're at a risk of increased risk of encapsulated organism infections. So you will ask for pneumococcal, influenza, meningococcal. Also, sometimes people, I mean, they're given meningococcal vaccine, and very importantly, varicella, because they have at an increased risk of viral infections with varicella. So you will ask for the history of intake or history of administering special vaccines like pneumococcal influenza and varicella. Now, these are the guidelines as to what vaccines need to be given to patients with nephrotic, when to be given. You don't really need to go much into detail about this, but remember when we're talking about pneumococcal, depending on the age and whether the child has been previously received or previously immunized with that vaccine or not, you need to decide whether he requires PCV 13 or PPSV 23. Again, the schedules are different depending on the age and depending on the previous immunization. There's pneumococcal, there is varicella, there's influenza, and hepatitis B is like any other case. But again, hepatitis B is important in case the child has not been vaccinated before. Okay, so these are the common vaccinations and the regimen as to when they need to be given and how they need to be given. Again, there are certain other things that you need to keep in mind while vaccinating these kids with nephrotic with live vaccines. So depending on how much steroid they've consumed, so like for example, if they've received high dose steroids for less than 14 days, then you can vaccinate immediately after discontinuing. But if they've received high dose prednisolone for more than equal to 14 days, then you need to wait for a month after discontinuing steroids before you give vaccines. So you don't really need to know or need to remember all this. But what I'm trying to emphasize on is that there are certain guidelines about immunization in a nephrotic which need to be kept in mind before you give special vaccines to these kids, depending on when was the last time that they consumed immunosuppressive therapies like steroids, what was the dose, what was the duration, etc., etc. Okay, so these are just guidelines in the ISPN 2021 as to how will you vaccinate your kids with nephrotic, specifically with your live vaccines. Okay, moving ahead, developmental history, socioeconomic. So developmental history most likely should be normal in a nephrotic, but again, that needs to be taken in detail with all the four domains. Socioeconomic history, according to modified Kupuswamy, what class they fall into. And again, knowledge, attitude, practice becomes very important because this is a chronic illness. So, what the parents know about the disease, what is their attitude, how compliant they are with the practice they have been told. So, say you have told them to follow up like probably every 2 weeks, every 4 weeks, whatever it is, whether they're compliant with the steroids, whether they know what dosage needs to be taken, are they taking it properly, what do they know about the prognosis of the disease, what do they know about what to expect in future. So the knowledge, attitude, and practice is very important when it comes to any chronic disease, just so like in a nephrotic. So this kind of concludes the history. So at the end, if you're asked to summarize the case, what will you say? So you will say that this is a 4-year-old male child who presented with chief complaints of periorbital puffiness, pedal edema, and abdominal distension with decreased urine output for 7, 3 days, and 1 day respectively, whatever the chief complaints are. Has generalized edema, which I think is of renal etiology, most likely nephrotic. Now, we have already seen as to why we think the edema is renal and why we think the edema is nephrotic origin. Okay, so renal etiology, edema, most likely nephrotic, with or without atypical features. So you can have associated hematuria or hypertension in a nephrotic, but they become atypical features. They're not usually seen in a normal nephrotic. So whether or not there are associated atypical features, whether this is a first episode or whether this is a relapse, and whether it fits into the definition of, say, frequently relapsing. What is frequently relapsing? If you look at the definition here, if you have two or more relapses in the first 6 months after stopping initial therapy, or more than equal to three relapses in any 6 months, or more than equal to four relapses in 1 year. This is the definition of frequently relapsing. That is the reason why it is so important for you to take a detailed history of what is the past history of how many episodes, how frequently, how has he responded, etc., to be able to classify the patient as either frequently relapsing, what is steroid dependent. So if the child has had two consecutive relapses on either alternate day steroids or within 14 days of stopping the steroids, then he falls into the category of steroid dependence. What is steroid resistance? If there's a lack of complete remission, even after giving 2 mg per kg of steroid daily for 6 weeks, then you would call him steroid resistant. So frequently relapsing, steroid dependent, steroid resistant are very important definitions and concepts that you need to understand, because you will have to classify your patient as either this, or this. And why is it important to classify them? Is because the treatment of each one is different. Okay. So whether this is the first episode or whether this is a relapse and what definition it fits into, and whether or not you feel that the child has any obvious complications on history taking, but obviously you would like to confirm it on your examination. So at the end, when you're asked to summarize your case, you will say that this is, edema, renal origin, nephrotic, atypical features plus minus first episode or relapse, and other associated complications. So that is how you summarize, and that is how your history taking in nephrotic is, over. I have tried to cover all the concepts as to why you have these different things in nephrotic. Why is there proteinuria? So concepts about what is nephrotic range proteinuria, why do you have edema, oliguria, infection, thrombosis, chronic complications, importance of taking history of your past treatment. All of these things become very important to understand before we go into the examination and the detailed discussion about how will you investigate this case, how will you treat this patient, how will you follow up, what do you need to tell the parents about prognosis. So that is the next part of discussion, which is going to be in the part two of nephrotic. Again, it's going to be super interesting, lot of concepts and lot of new things to learn. And so, yeah, so this kind of concludes today's class. Does anybody have any questions? If yes, you can put it in the chat box. And yes, there is also this feedback form which has been put into the chat box. So please fill it without fail. Does anybody have any questions with respect to the history taking in nephrotic? If yes, you can ask. Okay. So someone's asking, how do you ask for steroid intake? Yes, I was supposed to mention it at the end of the class. So usually steroids are given twice a day or can also be given once a day, but they're usually given with a glass of milk. Why? Because these steroids cause gastritis. Okay, so you don't really need to give an antacid along with the steroid, but usually they're given early morning with, a glass of milk. It can be given once a day or it can be also given twice a day, but it's never given empty stomach. And depending on the tablet strength which is available, like you can have prednisolone of 5 mg, 10 mg, 20 mg. A particular dose is told to the parents that this much needs to be consumed every day, and usually it's given for in different durations of time, whether it's the first episode or whether it's a relapse. So all of those things are, told to the parents that, you have to be compliant with this medication. This is the dose that needs to be taken for how long, and it's to be given with a glass of milk so as to reduce the possible gastritis that, is associated with steroids. So that is basically how you will ask for the history of steroids from the informant, whether or not the child has been started on that particular drug. Does anybody have any other questions on the history taking or concepts? If someone has not understood something, I can go over it again. Okay, I don't see any questions in the chat box. And so this concludes today's session. The next session will be again part 2 of nephrotic. Like I said, it's going to cover examination, investigations, treatment, theory, viva questions. So I'll see you guys next week, Saturday, 6 p.m. Till then, I would recommend that, before we do the next class, you should go over this presentation. You guys already have it, so that if you have any questions, if you've not understood something, you can ask me even in the next class. We can go over those concepts first before we dive into examination, because it's very important to understand these concepts to be able to actually understand and enjoy the second part of the session. So I hope you guys go through this presentation again quickly. And if you have any questions, we can discuss it in the next class. Okay, thank you guys for attending, and I will see you guys in a week's time. Bye.